Her, her areas of interest include neurological rehabilitation, health services research, and translational health research. Her topic for today is using implementation science to bridge the gap between research and practice.
Thank you for the invitation to come and speak with you today about implementation science and how this field might help you and your team, or perhaps even the hospital or the service that you work at, to enhance the outcomes of your clinical trials. My name is Dr. Marlena Klaic, and I'm a senior implementation science researcher at the University of Melbourne. I work with a brilliant team of 8 researchers, and we're all involved in a range of projects. And these include antimicrobial stewardship, rehabilitation, brain injury rehabilitation, just to name a few. We also have a hub and spoke model for our implementation research group, which includes a methods specialist hub, and then several other hubs that we support, such as a policy group, an emerging researcher group, and a clinician researcher group. We're also going to be setting up a hub for implementation research in LMICs. So perhaps that's something that we can talk about later during the question and answer time. So today I'm going to start by exploring the research practice gap before we move on to discussing why dissemination on its own may not be enough to ensure that research evidence makes its way to routine clinical practice. I'll then go on to describe implementation science and discuss one method that we can use to help us address implementation research gaps or problems. So let's begin. I'm sure you're all familiar with this picture, this image of research translation, and it illustrates an idea around how innovations or discoveries, whether that's drugs or clinical interventions, how they get from an idea, which is all the way on the left, through to healthcare policy, which is at T5, all the way over to the right. Phases 0, 1 and 2 primarily focus on the translation from basic science to human studies. And then from phase 3 onwards, the focus shifts to translating this new knowledge into clinical and health decision making. And this pipeline of research translation, it looks seamless. We're very much led to believe that there is automatic movement from one stage to the next. The assumption being that once you've proven that an idea is feasible, that a drug could work or that an intervention might work, that you'll automatically progress to that next phase of research. But in fact, there is a failure to translate research at every stage of that process. And this has significant implications for consumers of healthcare and for those of us that deliver healthcare, for our health services and our governments. There are multiple studies describing this problem of research and evidence failing to reach routine clinical practice. This is just one example that I've put up on this slide. A systematic review of published literature exploring quality of care in America included 48 studies and approximately 500,000 patients. So it's a very large review. Care episodes were categorised as either preventative, acute or chronic. And they found that there were large gaps between the care that people should receive and the care that they actually did receive at the hospital or at the primary care practice. Studies in the preventative care space found that 50% of people received low-value care. And that's care which has limited or no evidence, or it may be inefficient, or it's been superseded by something that has a stronger evidence base. For chronic conditions, 20% of patients received contraindicated care. And ideally, we don't want to see that ever happening for patients. We don't want to see contraindicated care being delivered, and we'd like to see a reduction in low-value care. So these results have been replicated across the world, and certainly in Australia as well, where we consistently see that we are delivering and receiving low-value or contraindicated care about 50% of the time. So why does this happen? Well, there are several factors that can act as barriers or enablers to the translation of evidence into routine practice. To begin with, as clinicians, as health professionals, we have to be aware that the evidence exists. And this requires time. It requires time away from practice or some way of finding out about that information. And then we also need the skills to be able to critically analyse or interpret that evidence and apply it in practice. The evidence needs to be applicable to the patient that's in front of us, the ones that we're seeing come through our clinical practice. And we need to have the skills and the confidence to be able to act on that evidence, and indeed even the resources available in that health setting. We can't assume that all health services have the same resources to be able to deliver each intervention. Without having these prerequisites in place of being aware, accepting, being able to apply, being able to act on it, we risk the following types of care gaps, and that includes slow uptake of new interventions that are clinically effective. And we know this is a failure to deliver high value care. Or we see premature or continued delivery of interventions that are ineffective. And we know this as low value care, and I described that in the previous slide. It also contributes to a failure to keep up with gradually emerging evidence. It results in unwarranted variation in care, where a patient might present at a different health service and get different type of care. So what can we do about this failure of research translation? There are a range of broad strategies that have been tried. Of course, clinical guidelines are important, but they are not enough on their own to help us change practice. Continuing medical education is also important. It helps us keep our skills and our knowledge up to date. But knowledge and skills are only two of a multitude of factors that might be influencing our behaviours in relation to the delivery of care. So despite these strategies, the care gaps continue. So much so that a few years ago, a Viewpoint article in JAMA talked about the disappointment in this value-based era. And the authors state that key improvement programs, so these are quality assurance or quality improvement programs, have not actually improved patient outcomes. So this is an enduring problem, that patients don't consistently receive the best quality of care. It doesn't matter where we are in the world, whether it's Australia or India or America. Healthcare professionals don't manage to deliver the quality of care that we aspire to deliver, hence the need for implementation science. So about 25 years ago, Richard Grohl and Jeremy Grimshaw proposed that we need to match evidence-based medicine with evidence-based implementation. And the argument that they proposed in this paper was that most quality improvement initiatives are based on the beliefs of decision makers, rather than on the growing theoretical and empirical knowledge about behaviour change and organisational psychology. And that was very much the seed for starting this field of implementation science. So what is implementation science? Implementation science is about methods that promote the uptake of research findings and evidence into routine clinical practice. Where knowledge translation is about the act of developing and disseminating the knowledge, so for example, developing clinical guidelines and publishing them, where that finishes off, implementation science starts. So it's about how to get that knowledge into actual practice. So implementation science would be about the methods that influences adoption of tools like clinical guidelines into practice. And we have our own journal, which is well worth looking into. So before we go any further, I want to make a distinction between implementation practice and implementation research, because I'm quite sure that there are many people in this audience who are brilliant at implementation practice. And that's where health systems and managers and policymakers try and reduce evidence practice gaps with the goal of improving quality of healthcare and health outcomes. So it might be about starting up a clinic, and that's certainly something that I've done. But implementation research is about the scientific endeavour that builds the body of knowledge about whether a given implementation strategy is effective and cost effective. So it goes further than the practice of a new clinic and trying to find out, well, what made it work, what made it sustainable, and can we scale that up to other settings? So in the same way that clinical research supports clinical practice, implementation research support implementation practice. So in implementation research, the samples or the research participants are the healthcare professionals, and the objectives are usually to investigate an evidence practice gap. And the measured outcomes should be about what practitioners actually do. Are they delivering that evidence-based care? Of course, we care what happens to patients, but the proximal effect of an implementation intervention is the behaviour change amongst health professionals. And you can see there in the table the comparison of clinical research. We've done a PICO there in comparison to implementation research. So implementation involves healthcare professionals or systems or organisations or services doing something different. And that means behaviour change. Someone has to change their behaviour. So if we're trying to build an evidence base to support implementation efforts, then we can draw on the methods and the theories and the evidence from the field of behavioural science and organisational psychology. So let's look at a couple of approaches. Actually, I'm only going to focus on the one approach today to addressing the evidence practice gap. But later on, we can talk about another approach that very much focuses on the health service. So this method that I'll discuss is what I would call a more traditional approach to implementation research, where we begin with the implementation problem. So Simon French and colleagues detailed a series of steps to help guide researchers, managers, even clinicians through a stepped process to behaviour change. And I really like this 4-step process because it makes it, it's iterative and it makes it simple to follow if we want to implement something new into practice. So the first step in Simon's process is to identify, well, who is it that needs to do what differently? So specifying who needs to do what differently, it sort of sounds like a straightforward process, but it's critically important to identify this with enough detail so that we don't miss out on critical information and end up with a failed implementation project or plan. So we have a framework that we use. It's pretty simple and straightforward, and it helps us specify the behaviours that we're trying to induce, the things that we want people to do in an implementation project. And this framework is called ACT. And ACT is an acronym, and it stands for action, which is what is the action that can be observed or measured? What is the thing that we want people to do? The actor, or who is the person or the people who should be doing the action, delivering the intervention? Context, where should this intervention be happening? And that could be physical context. Should it be at the bedside of the patient? Or it could in fact be an emotional context. Does it need to happen when a patient is calm, for example? The target, well, who is the intervention being done with, or for whom is the action performed? So it's typically a patient, or it might be a carer. And time, when should this intervention, when should this behaviour be occurring? How often should it be occurring? For how long should it occur? So this maps very well to Simon French's first step about specifying, well, who needs to do what differently? Just want to show you an example here of what that might look like in the context of a project that looked at how we might be able to improve compliance with hand hygiene. Of course, this was tremendously important during the pandemic. But if we look at this, it shows you that it can be quite complex. You know, we've got the actor, like who should be using alcohol-based gel? So that's the action, that's the behaviour we want to happen. Who are the actors? Well, it should be the physicians, the nurses, the residents, the therapists. It should be happening in the patient's room. The time it should be happening is before and after touching a patient. And the target is, of course, the patients. We don't want to be touching or dealing with a patient if we don't have hands that have been sanitised. But then we have some ancillary behaviours. So they may not be the focus of our implementation project, because we're very focused on the physicians and the nurses using the gel. But what about the people that are involved in making sure that the gel is filled? I mean, how many times have we gone to sanitize our hands and found that the gel dispenser is actually empty? So those require some consideration as well, because what if we're able to change the behavior of the physicians, but we haven't considered making sure that the gel dispenser is full and that there is an ordering system in place to ensure that that happens routinely. So you can see that it's not overly complex, but it requires some detailed consideration. The next step would be to think about, well, what factors influence whether somebody is going to do the behaviour or not? So this is where we look at the barriers and the enablers. We can't just assume by telling someone to do something that they're going to do that. That largely never works. We need to be a little bit more nuanced in understanding why somebody would do something, or indeed why they wouldn't. So this is about barriers and enablers, and some of you may be familiar with the theoretical domains framework, and this is underpinned by decades of behaviour change research. So Susan, Mickey and colleagues synthesised the key factors that are associated with behaviour change from 33 theories and 128 constructs, and they narrowed that down to 12 construct domains, which was then subsequently validated, resulting into 14 domains. And that essentially provides us with topics to explore that are known to affect behaviour, and it can help us to understand barriers and enablers to behaviour change amongst healthcare professionals and patients. And we often do this either in a semi-structured interview, but I've also done it in focus group discussions, and I've also done it in a survey format. So here we have an example, and I'm sorry that's a very busy slide and I'm not going to go through all of it with you, but you will have this available. But we have those 14 domains on the left-hand side. So we know that these are factors that influence whether we're going to deliver an intervention or not. And some of these make a lot of sense to us. I mean, you have to have the knowledge about the condition, knowledge about the intervention, and we know that you need to have the skills as well. But other areas that I see come up time and time again as barriers or enablers are things like beliefs about consequences. If we don't think the intervention is going to make a difference to the patient in front of us, we're not likely to deliver it. So, what if there's a strong evidence base, but we have health professionals who aren't aware of that, and they say, well, I don't think that that using that antibiotic will actually change the symptoms in that patient. So that's a very important one to understand and identify. Similarly, beliefs about capabilities. You may have the knowledge and you may have received the training, so knowledge and skills may be there, but that doesn't automatically mean that you feel confident to deliver the intervention. And I've seen that in the context of assessments for oral health, that there's an expectation that nurses will be able to do that, or that speech pathologists can do that. And in fact, they may have had the knowledge and the skills, but they don't feel confident about what they're seeing inside the oral cavity. And the next step then is to, once we've worked out what the barriers and enablers are, is to think about, well, can we change the behaviour? What can help us? What strategies or techniques can help us overcome those barriers and enhance those enablers? So here we're talking about behaviour change techniques. And this is just a snapshot of a tool that's available online, which I would really encourage you to go and check out. It's wonderful, where you can map where your barrier is and select an implementation strategy. So where you see those green squares is where there is an evidence base, so there is an effect size there to be able to go and select that implementation strategy. So for example, if you have a look at the one that says BACA, that's beliefs about capabilities. If that's a problem with the health professional group that you're working with, then we know that a strategy that can change that is problem solving, and so on and so forth. And then the final step in Simon French's 4-step process for supporting change in health services is about measuring the effects of the implementation strategy. So of course, the selection of your study design will depend on several factors, including the level of evidence available for the intervention, the resources, the research question, and so on and so forth. But I want to take a moment to briefly discuss hybrid designs, because they provide us with a tremendous opportunity to measure implementation, potentially whilst we're also measuring efficacy, clinical efficacy. So Curran and colleagues in 2012 proposed a dual focus in the same study on both implementation and clinical efficacy. This has really kind of set the research world on fire in many ways. I have probably the majority of my work sits in hybrid designs. So Curran suggested that a hybrid approach could speed the translation of research findings into routine practice. And why is that? Well, because instead of waiting the many years to start from phase 0 if you recall the research translation pipeline, before thinking about translation, he's proposed that we start thinking about it right from phase 0. So he suggested 3 types of hybrid designs that are really on a continuum. So going from the left, there's a greater emphasis on testing clinical effectiveness. So for example, a hybrid type 1, the primary aim is to say, well, does this intervention work? But at the same time, you can embed an evaluation to identify the context for implementation. So you can look at what the barriers and the facilitators are. You won't be testing an implementation strategy, but if there's good signalling that this intervention is going to be effective and you move on to a more definitive trial, you could be ready to go with an implementation strategy because you've done some work in that type 1 in that first stage. A hybrid type 2 is when you already have some suggestion that this intervention works, but you're still requiring some more evidence. But you can take the opportunity then to also look at the impact of an implementation strategy, or perhaps be looking at some implementation outcomes. And then a hybrid type 3 is when we have a very strong evidence base. We know this intervention works, but then we're testing the effects of the implementation strategy. And the secondary aim is looking at the clinical outcomes. So the point is that we're joining up two efforts so that we're not sitting on our hands waiting for the clinical innovation to come to light. We do need to be careful and not overuse this approach, but it's very good to keep in mind. Just quickly, because I'm running out of time, I wanted to touch on whether we think implementation research and science is worth it, because sometimes people say, look, this is too expensive. It takes too long. Can we even afford to take this approach? Well, a paper published by Schrank and colleagues in 2019 calculated the annual cost of waste in the US healthcare system based on the failure of care delivery, so not delivering care that's indicated, and over-treatment or ongoing delivery of that low-value care. So those things that we discussed in those first few slides. And they found that failure of care delivery costs almost 4% of their healthcare spend, which was up to $80 billion. This is annually, every single year. And over-treatment or low-value care costs nearly 3%, of their healthcare spend. So I extrapolated those figures to the Australian context, and I'm sure you can do that for CMC law, or even broader to the Indian context. But for the Australian context, we have a total health spend of nearly $106 billion. Oh, no, sorry, I updated these slides. We have a total health spend of just over $240 billion. That's in 2021. So if we look at what the failure of care delivery is, it costs over $9 billion every year. And over-treatment or low-value care costs over $6 billion each year. So by addressing the two components of care gaps, by addressing, stopping the low-value care as much as we can, or being sure that we're delivering, evidence-based high-quality care, we can save in Australia potentially $17 billion every year. So my argument is that we can't afford not to be engaged in implementation research. And certainly this is reflected in funding in Australia, where pretty much every grant that we go for requires an implementation plan. So how might we do this? So we're back at this research translation pipeline where we started earlier on. We know that funders are most often interested in the left side of research translation, the innovative bit, the drugs, the biomarkers, the genes. But we also know that there's not going to be any impact on health outcomes from that innovation until the piece happens in T4. That's on the right-hand side. So let's talk about timelines. We know that even with well-resourced drug companies, it takes up to 20 years from innovation to human trials. And that's probably quite conservative. So then let's say you need to do some replicate trials and write your guidelines. There's another 10 years. Then we hear that it takes about 17 years for the evidence to hit routine clinical practice. So what can we do about this chasm between innovation and impact? So this is the big question, and I think that this is what we need to do. We need to get the T4 scientists, the ones doing the implementation research, to start collaborating with the T0, T1, T2 innovation scientists and the clinical trialists. By using things like hybrid designs, we can anticipate the implementation problems before they start, so that when we get the effectiveness data, we're ready to go with the implementation strategies and plan, and so is the system. Thank you very much for listening to my presentation, and I will be available for answering some questions.
Thank you, Dr. Marlena. That was a totally new science for us. Um, so as we wait for questions, based on the last slide you had put up, I just want to ask you, where do you find it most difficult, the gap? Where you find it more difficult to address the gap, either in the researcher's side or with the doctors, or applying whatever evidence we have developed on a population level?
That's a fantastic question. Thank you so much for that. I think, you know, from my experience, there's difficulties across all of those areas, and I think that most of us would have experienced that frustration, whether it's trying to get the evidence in our own practice, trying to get it to the patient, the researchers working with the health professionals. So I think, you know, I think there are challenges all across those areas for lots of different reasons. But having said that, I think there's also lots of great opportunities in all of those areas. And a lot of my work, probably most of my work, is with health services and health professionals. I do some work with patients as well, trying to understand their perceptions of health interventions. But largely my work is with the doctors and the nurses and the clinicians.
Thank you, Dr. Marlena. And I totally relate to your empty gel bottles, like, because you convince
Yes.
everybody to wash their hands and use the Sterilumen, but it's empty in the morning. Yeah,
Oh,
so
me too. That's and it's funny, every time I talk about that, every single health professional says that happens all the time. And it's interesting because we often, when we think about, I want to change that healthcare practice, we don't think about those other things such as the ward clerk. Do they need to do they need to order ultrasound gel? Do they need to order a syringe of a certain size? Because we might be able to improve the physician's practice, but if those other things let us down, like the empty gel bottle, then we've got a failure of care delivery that's really nothing to do with the physician.